Tēnā koutou katoa, ko koutarana te whakapapa rangamai, no Mataura o, ke te noho o ke Aotearoa, ko Desma toko ingoa, tēnā koutou katoa. Take a deep breath. It's a little bit different doing it to peers than doing it to students. I'm here today to talk about my PhD research, which involves exploration of nursing students' attitudes towards their peers with disability. So I am a staff member and a student here in the Faculty of Health, so working in the nursing programs here as well. So I am about halfway through the PhD, maybe slightly more, but probably should be a little bit further along. So my journey, my background, to why am I studying this? Having worked in nursing education, both here in New Zealand and in Ireland for the last probably 15, 16, 17 odd years, my reason for studying this is just that when we are working with students with some disabilities, they struggle to progress well within the pathways. They also struggle sometimes to get the grades that they require for further postgrad study. So sort of talking more along the lines of students that have sort of those softer learning disabilities, so things like the dyslexia, ADHD, and neurodiversity as well. So within educational programs, we can offer accommodations and supports, but unfortunately for students to get those accommodations and supports, they actually need to register as having a disability so that it's a fair and transparent process, and then they can get some supports for their study. So what I wanted to look at was when you start a PhD, you start sort of looking up here, and then you have to funnel it all the way down to something in particular. So the research or the literature that I looked at was looking at looking at supports for students with disability in tertiary education, particularly from a nursing perspective. But what I was sort of finding was that actually the nursing workforce in particular did not particularly have great attitudes towards their peers with disability in nursing. Nursing educators or nursing lecturers did not have particularly positive attitudes towards students with disability in nursing education. And what was kind of missing in that was, well, actually, if we've got poor attitudes towards supporting people with disability within the nursing workforce, within nursing education, but what do the students themselves think about supporting each other within that environment? So that's where I landed. So looking to have that more inclusive workforce from a nursing perspective, nurses are fantastic at looking after other people, not quite so fantastic perhaps at looking after each other. In New Zealand and internationally, we have an ageing population, so we will have a shortage, well, we do have a shortage of nursing, and we have an ageing population of nurses as well. We also have that real need for a more diverse and inclusive workforce. From a New Zealand perspective, we don't really have a whole lot of data on nursing education, students with disability within education, what accommodations or supports they may or may not be getting. So we don't actually know, there's no sort of national database of that information. So my research questions and aims, and what I've discovered along the way is that sometimes you tweak and you change this slightly as you go along, and you think actually that probably wasn't quite the question I wanted to ask, and it does sort of emerge a little bit. So I started off with, I landed here, and it's probably changed slightly again. To what extent does lived experience with disability actually influence nursing students' implicit and explicit attitudes towards their peers with disability in pre-registration nursing education? So pre-registration nursing education is any education program that leads to registration as a registered nurse or an enrolled nurse in New Zealand. So that includes a Bachelor of Nursing, enrolled nursing program, and graduate entry pathway to nursing as well. So you'll notice that I've got in there implicit and explicit attitudes. So our explicit attitudes, we can say that we have great attitudes, and any of the attitudinal scales that we use, of course, are subject to social desirability bias. Implicit attitudes is a little bit harder to define, detect, and explore. So I'll talk a little bit more about that. Our aims were to sort of compare attitudinal responses to measures attitudinal scales among different lived experiences of disability, and then to integrate that with qualitative, so quantitative and qualitative, for a deeper understanding. So just sort of thinking about lived experience of disability. So disability is quite difficult to define. So I haven't kind of gone into defining disability as such, but I did want to talk about what do I mean about lived experience with disability. So we created 4 different groups of that. The first group was having their own lived experience of disability, so they have a disability themselves. The second group that I looked at or included in the survey was social contact. So the background behind that was having an equal social relationship or equal status relationship with somebody with a disability, further defined by regular contact within that equal status relationship, not within a work-related capacity, and at minimum on a weekly basis. So some of the literature that I had explored had said that contact needed to be on at least a weekly basis to count for lived experience. My third group then looked at professional contact, so it's regular contact in a work or a volunteer capacity, to separate that out from a social one. And then my fourth group was people that identified that they either had no or very minimal or didn't fit into the other groups. The research design, so for anybody that's starting their research, don't do sequential mixed methods research because it takes too long. It's a little bit... I should have thought about that. So it's explanatory sequential mixed methods design. So phase 1 is my quantitative data collection. So that has required a nationwide survey. Analysing those, so I'm stuck in these 2 phases, the 2 blue phases there, quantitative data analysis and developing qualitative questions. So part of that sequential mixed methods design is that the first phase designs and plans for the second phase. My phase 2 will be qualitative data collection, and it's aimed at exploring meaning behind the quantitative. So I've got the quantitative stats, then want to explore what does that actually mean. And as with all mixed methods research design, you must have the integration at the end of it. So I've started the joint display because joint displays are talked about a lot in mixed methods research. So I'm starting to gather that quantitative side and questions to kind of go, that could probably be explored a little bit more. So that's my research design. Phase 1 data collection was a nationwide survey. The first challenge was actually accessing nursing students in different nursing programs in different institutions across the motu. So there are 21 schools of nursing in New Zealand. I was given access, so I had to apply individually to each one of those. I got access to 16. One said no to protect their participants or their students within a specific program, and I didn't hear back from 4 others, even with regular have you had a chance to consider? So not too bad. It was a survey. I looked at demographic data, age, ethnicity, gender, the program type, the year and the stage of progression through the program. So our Bachelor of Nursing is a 3-year program, our enrolled nursing is 18 months, and graduate entry pathway is 2 years. So a little bit of difference over that. Looking at entry pathway, so did people enter their programs with NCEA level 3? Did they do a level 4 preparation course? Other qualifications. So some of my preliminary results are kind of fairly logical in that you couldn't enter the graduate entry pathway actually if you didn't have another qualification. So, looking at disability, lived experience as I've explained, the type of disability. So what I didn't want to do was to put onto people what I thought a disability actually meant. So I tried to keep that survey open to sort of say you can identify as having a disability or not. The next set of questions were, do you have any of these aspects, so that people could say, well, actually I don't identify as having a disability, but actually I do have this. To try and open that up a little bit. Just looking for information around accommodations used. Were they registered for support services? So in the data that came through, the descriptive data, quite a few were not registered for support. They didn't use accommodations, and staff didn't know about it either. So Measures of attitudes determining, so implicit, explicit. One of the biggest challenges I had was embedding an electronic computer-based disability attitudes score into a Qualtrics survey. Yeah, that was great fun, not. Anyway, a website actually developed a JavaScript for me, which I was able to embed onto that. So it's a computer-based. It's done the Harvard project. Harvard Implicit Project does loads of implicit attitudes tests, so that's where it's come from. Explicit scales, as I say, they're self-reported. They are subject to social desirability bias. So I used one called the NANS, it's Nurses' Attitudes Toward Nurses with Disability Scales. It was not particularly, the psychometrics for it weren't particularly great, but because it was the only nursing-focused one, I included it. And the other one was a multidimensional attitude scale, which included cognitive, affective, and behavioural subscales. Phase 1, I can't determine a response rate because I actually don't know how many nursing students are enrolled in nursing programs in New Zealand. The number of survey responses I got was 259 at an estimate of between 2,000 and 3,000 nursing students across the country. So, and the number of completed responses minus major missing data was 180. So missing data. Actually, SPSS, as I discovered on the weekend, can actually do a value and tell you exactly where your missing data is. And most of it, interestingly, was in the attitudinal scales, not in the demographic data. I've done some preliminary analysis, descriptive stats. I won't bore you with descriptive stats. And that is planning for the next stage, which is regression analysis. Just to highlight lived experience with disability, 6% didn't complete that question. 37% had no or minimal contact with persons with disability, and the rest of them are reasonably evenly spread. So when I combine lived experience, if I talk about people that have got lived experience, there's a bigger number with lived experience. 18% with their own, 18% with professional, and 21% with social contact. Attitudinal scale results, so this is just descriptives. This is the implicit attitude scale. It comes across in 7 categories, and it's actually the way of measuring it in the background is it measures your time response, the means between different time responses. So it flashes up with images of people with disability. It is focused on physical disability, and it has positive and negative words, and it times your response to that, and then does a calculation which you can download from the website, which makes it easy. So this was the results from the respondents in my survey. So you can see on the graph there a huge tendency towards preference for able-bodied people. So that's the language that attitudinal scale uses, and that aligns with most of the. It's hugely widely used, and that aligns with the data from their database. So strong preference for able-bodied people, moderate or mild preference, and a very small amount at the other end. The explicit attitude scale results, as expected, were more positive because we kind of sort of tend to do that as a natural progression. So you can see on this side closest to me, I'm going left or right, I get my left and rights confused now. The MAS scale, that was the multidimensional scale. The mean was higher than the NANS scale, but the bar charts tell us the difference. So while the NANS scale had a slightly lower mean rate, the range of responses was actually more closely gathered, so it was more consistent on that particular scale as opposed to the MAS scale. So they were just the 2 attitudinal scales. This is an image of one of my many different spreadsheets that I've colour-coded and put loads of comments on and attempted to understand what the numbers and the asterisks actually mean. Because it's preliminary and because it didn't give me the result that I thought I might have got, I went back and did it again on my supervisor's advice on the weekend and actually got the same result. So no, basically no significant relationship at this point in time between lived experience with disability and attitudes towards people with disability. So the attitudinal scales are not showing me that there is a relationship there at all. I did come up with several weak statistical significant demographic variables, and when I looked at that across with crosstabs, basically they were all very explainable and logical, so nothing in there. And that led me down that discussion of statistical versus practical meaning. So small group, I had quite a small sample size, and then within different groups, quite small numbers within those different groups as well, so that has impacted on the values and the correlations. So, phase 2 to come, and because I'm out of time, many thanks to all my survey respondents, and many thanks to my supervisors, Maren and Kathy, and to my wonderful family who put up with me when Mum's grumpy and trying to make sense of statistics. Thank you.